Aspirin mechanism and clinical use. Aspirin is a nonsteroidal anti-inflammatory drug, NSAID, widely used for its antiplatelet, antithrombotic, and analgesic properties. It is indicated for cardiovascular disease prevention, migraine management, and postoperative care. Overview. Aspirin, also known as acetylsalicylic acid (ASA), is a widely prescribed NSAID with potent antiplatelet and antithrombotic effects. It is available in various formulations, including immediate release (IR) and extended release (ER) forms, with dosages ranging from 75 mg to 160 mg. Its mechanism of action involves the inhibition of cyclooxygenase (COX) enzymes, which are responsible for the production of prostaglandins involved in inflammation and blood clot formation. Pathophysiology/mechanism of action. Aspirin exerts its antiplatelet effect by irreversibly inhibiting the cyclooxygenase 1, COX-1 enzyme, which is primarily expressed in platelets. This inhibition prevents the formation of thromboxane A2, a potent platelet aggregator. Additionally, aspirin has a mild effect on COX-2, but this is less significant compared to COX-1. The antiplatelet effect is dose-dependent, with higher doses leading to greater inhibition of platelet aggregation. Clinical features/indications. Aspirin is indicated for the prevention of cardiovascular events, such as myocardial infarction and stroke, in patients with a history of coronary artery disease or hypertension. It is also used for the treatment of migraine headaches and as an adjunct in postoperative care. The recommended dose for primary prevention is 75 to 100 mg once daily, while for secondary prevention, it is typically 75 to 160 mg once daily. In patients with renal insufficiency, the dose should be adjusted based on creatinine clearance (CrCl) to avoid adverse effects. Diagnosis/monitoring. Aspirin-induced bleeding is a common side effect, and its severity can be assessed by monitoring for signs of hemorrhage, such as bruising, gastrointestinal bleeding, or neurological symptoms. Laboratory monitoring includes regular assessment of international normalized ratio (INR) and prothrombin time (PT) to evaluate antithrombotic effects. In patients on long-term aspirin therapy, monitoring of renal function and platelet count is also important. Treatment/management. For patients experiencing aspirin-induced bleeding, the treatment involves discontinuing aspirin and managing the underlying cause of bleeding. In cases of gastrointestinal bleeding, endoscopic evaluation and intervention may be necessary. For patients with renal insufficiency, dose adjustment is crucial to maintain therapeutic efficacy while minimizing risks. In cases of severe bleeding, hemostatic agents or blood transfusions may be required. Key clinical points. Key points. Aspirin is a potent antiplatelet agent with a well-established role in cardiovascular disease prevention. The antiplatelet effect is dose-dependent, with higher doses leading to greater inhibition of platelet aggregation. Monitoring for bleeding and renal function is essential in long-term aspirin therapy. The recommended dose for primary prevention is 75 to 100 mg once daily, while for secondary prevention, it is typically 75 to 160 mg once daily. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.